Well, thank you very much for leaving some time to talk for me. So I'm going to talk clinical trials, success and challenges. And I'd like to ask you, who are health professionals dealing with this disease? Would you raise hands? And who are patients and families? Okay, very good. So I have some ideas. So once again, really we had wonderful discussion about epidemiology and including some clinical trials. So I'm going to concentrate to clinical trials, success and challenges. So I have some conflict of interest. I got grants from various areas and also doing clinical trials, biogen, cytotherapeutics, and some so forth, but certainly I don't have any stocks and so forth. So the fact is we had a lot of clinical trials. 50 drugs has been studied in half centuries, except for a couple of medications, everything failed. And there are many issues we are going to present today. Also, only 2 drugs has been shown to be positive and consequently approved for the treatment of ALS, which is Riluzole and the Neurologista medication, dextromethorphan and quinidination. Riluzole is a disease-modifying drug. That means directly associated with cause of disease, prolonging survival and maintaining function. And also dextromethorphan quinidine combination compound, so-called Neurologista, is a symptomatic treatment. It's a disease-modifying treatment and symptomatic treatment. And if disease-modifying treatment is difficult, we have to improve patient symptoms so we can maintain, improve quality of life and function. So I'd like to speak a little bit about Riluzole. And Riluzole was developed almost now 18, 19 years ago, long time ago. Still we're using Riluzole. Why? This is the only medication we can prescribe, nothing else. So it was developed, it was approved by 2 controlled phase 3 studies, actually phase 2 and phase 3 studies. And then there are various studies done, as you can see, Menangel, Mitchell, Traynor, Brooks, and Turner. They looked at, without control, how long really Riluzole prolonged life. Now, surprisingly, not only a few months to even 21 months, there is this so-called post-hoc analysis, which is not randomized, not controlled, placebo-controlled. Therefore, some people believe this result, some people don't believe this result. But clearly, Riluzole is probably better than you think. And there are 3 reasons we are now prolonging survival with this patient population with ALS. Why? Clearly, we improved patient care without any doubt about the disparate clinic team approach. The other one is patient awareness improved, improving respiratory care, nutritional care, everything. And then probably 3rd reason is Riluzole. So those combination is compared to patient survival in 1990s when the medication developed compared to now, patients seems to live longer without any doubt. There are various studies show that evidence. So benefit of survival and quality of life, you can look at, there was a very interesting clinical trial, Zariplodin, which was 6 arms, and including placebo, Riluzole alone, and then low dose, high dose Zariplodin with or without Riluzole, which showed again comparing a placebo and Riluzole arm without any medications. Placebo did poorly compared to Riluzole. Therefore, Riluzole proven to be again beneficial, but tiny bit. So again, Brooks showed a similar result, and Riluzole is clearly slowing disease in terms of increasing survival. So ALS pharmacotherapy specific treatment. Treatment with riluzole is considered to be the standard of care because this is now shown based on level 1 studies, class 1 level of evidence, and then clearly showed modest benefit in prolonging survival of ALS patients. Riluzole treatment only now approved disease-modifying medication for the treatment of ALS at the moment, as I mentioned. However, Cochrane database means all study putting it together, if you look at, still our survival benefit is only 2 months. And someone says 2 months, what does it mean? Almost nothing. However, that's the average, and probably some patients get more benefit, some patients may not get any benefit. So that's what the problem is. And the Ireland population-based study showed 4 months survival benefit, but multivariate analysis failed to find riluzole to be the independent predictors. That means riluzole is not only the reason why people live longer. Probably multidisciplinary care and other factors are associated with. So what happened in terms of riluzole and alternative treatment? People tend to not to take riluzole because of such modest benefit. However, they are spending a lot of money for alternative treatment, anti-oxidative medications such as CoQ10, vitamin E, and all those tends to spend more money than riluzole. And yet, those alternative medication has no evidence to show any benefit. That's the fact at the moment. So reasons why not taking riluzole, if you look at, too expensive. In fact, riluzole costed $1,000 a month in the United States. However, now we have a generic medication. It costs about $200 to $300, clearly better, but still Medicare, such as government insurance, would not pay outpatients, so that still remains a problem. And do not believe to be beneficial. Physicians do not believe, and the patient do not believe. Never heard of it, probably just don't know anything about this medication. Some doctor would not talk, and stopped due to side effect. That could happen, but I would say side effect of riluzole is quite modest, and doctor discouraged it, and concerned about the side effect and others. So various reasons why people are not taking medication. But again, as an expert, for fairness, I explain to the patient pros and cons, why people take medication. I think I'm responsible to tell the patient what's available and what's the benefit, what's the side effect, and so forth. So another medication has been approved, people using is dextromethorphan and quinidine combination. And we don't know why this medication works, but the theory says this dextromethorphan works through sigma-1 receptor modulate, essentially anti-glutamate, particularly motor neurons and other neurons aggregated in the brainstem areas. So probably you heard the pseudobulbar affect. This disease is causing sometimes uncontrolled sudden laughing and crying. And if you follow the patient, significant proportion patient develop such crying, laughing, uncontrolled. But this is not only specific for ALS, but can occur in many other diseases, such as multiple sclerosis, Alzheimer's disease, and chronic brain traumatic encephalopathy, and so forth, but higher incidence in ALS. So they looked at the benefit of this dextromethorphan and quinidine. Actually, Dr. Richard Smith with San Diego, who did clinical trials as a disease-modifying treatment with dextromethorphan. And he did the studies, and the study turns out to be negative to benefit for the disease-modifying. When he stopped the medication, some patient came to me, please don't stop the medication because my uncontrolled laughing or crying returned after medication stopped. So Dr. Richard Smith thought, that's unusual. Why? That's the beginning. They tried this medication for, we call PBA, pseudobulbar affect. So looking at how medication controls dextromethorphan-quinidine combination, dextromethorphan alone, and quinidine alone, and what they found, blood concentration clearly improved. Quinidine is anti-metabolite to dextromethorphan destroyed in the blood. So the dextromethorphan can stay in the blood, so more dextromethorphan goes to the brain. So they did a study, and a primary endpoint is called central nervous system study, Leber scale. They looked at how Leber scale changes, and also number of laughing, number of crying also change from baseline to quality of life, a change of baseline to quality of relationship to those scores. So they looked at, and what they found, clearly combination of dextromethorphan and quinidine did better in terms of reduction compared to quinidine alone and dextromethorphan. And the same way, they looked at significant greater improvement score with the combination, and change in the score of 3.5 represents a 50% of decrease in number of episodes per week. So every aspect of this medication worked well. So based on this positive result, medication has been approved for the past few years, and we have been prescribing this dextromethorphan-quinidine combination compound medication. In fact, without any doubt, patient has very quick improvement. So just also quality of life is improved with dextromethorphan-quinidine, and hope this works. I'm hoping I'm pushing right button. So this was a very interesting study, and you should know. This study done by a company called Avenir, and what's unique was this is the first, in my knowledge, including South America, Brazil, and Argentina. So great proportion of the patients are included from Brazil and Argentina. So you should know this medication, because this is multinational studies including South America. And also currently, probably this medication may benefit the bulbar functions and also even survival. So the medication developed for symptomatic treatment may benefit for disease-modifying changes. So I'd like to speak a little bit more general sense of clinical trials. And I don't expect you can read those small letters. And what I'd like to say is past 20 years, so many medication has been tried. If you can read excitotoxicities, growth factors, neurotrophic factors, I showed earlier my talk, wobbler mouse, CNTF, BDNF, those are neurotrophic factors. Also neuroinflammations and oxidative stress, apoptosis, and also mitochondrial dysfunction, genetic defects, autosome and perioxisome, target for astrocyte and proteinopathy. So many different areas. So problem, I shouldn't say problem, but maybe I can say problem is so many different areas. If you look at neurons, motor neurons are believed to be the source of a problem. And you can see so many problems, mitochondria and energy metabolism, mitochondria, or protein production, endoplasmic reticulum, and so oxidative stress. And if you look at so many areas, motor neuron has different target. Blue arrow shows medication has been tried. And also astrocyte, microglia, and vascular permeabilities, all those targets has been tried. But also outside of motor neuron, there are target antioxidative, growth factors, nutritional treatment. But what we don't know, as just we heard about epidemiological discussions, lifestyle factors, environmental insult, the dietary, psychological factors, so many different targets. Any medication targeting one area, and the medication has been negative, and any disease, name difficult disease, terminal cancers, HIV, even tuberculosis, diabetes, very rare to treat with one disease. You need a multiple combination of effective medication to conquer such disease. Eventually, we have to do multiple combined treatment, but we must have one or two or more of effective medication on one target. So already we heard the phase, preclinical, phase 1, phase 2, phase 3, phase 4, and the preclinical studies, we identify medication from 10, 100,000 chemicals to reach one possible medication, and then try to, in animal models, then first time go to human studies phase 1, and the safety and the feasibilities. If it's shown to be okay, then goes to phase 2. What kind of outcome, what kind of test is better? How many patients do we need to testing in phase 2? And hopefully multiple phase 2 studies, then final pivotal studies, phase 3, to demonstrate the medication is effective. If medication approved, goes to phase 4 to really in wider population, medication is safe. So that's the stage to develop medications. So again, I am sorry to show these slides, and if anyone interested in reading a paper, you can look at it. This is just last September, not quite a year ago, published Lancet Neurology about the critical issue of clinical trials in ALS, and about 20 some medication has been tried in the past 10 years. And every medication turns out to be negative. It's such a disappointment. Everything tried, but you know why? Because there's so many different targets. If you can criticize, easy to criticize, by the way, to almost I feel I'm a part of a fault, part of a problem, but clinical trials shooting, closing eyes to target. And we got to know the mechanism of disease. Unless we know better in terms of disease mechanism, we may not find final medication. But we cannot wait how long? Next year or next 5 years, next 10 years? We have to try all possible medication without doubt. So we have to do parallel ways. We have to identify disease mechanism. We have to put effort almost half as clinical trials. My sense, we are putting more effort to clinical trials, a lot of multi-million dollars to try with the medication, but same amount of effort to try to find the disease mechanism, not animals. But in humans, you have to study patient to find the cause. I did animal studies so much in the past, as I said. Animal studies is so important, without any doubt. But the cause of disease must be existing in a human patient. We have to study patient themselves. So any case, we did many clinical trials, turns out to be negative. So next slide, hopefully. Okay, so there are many papers published, and also investigators says why clinical trials fail. Must be some reason. So this is not my opinion, not my assessment, but investigator who wrote the paper assessed why it went wrong. So I'll tell you why. Rationale, maybe they put too much emphasis on SOD models. There are many papers admitted. And also interpretation of phase 2 result. Phase 2 result, you have to have a good result. So based on the phase result, a little bit of positive goes to phase 3. You have to prove. So I'm critical, sorry to be critical. And again, I'm myself talking about I am a wonderful problem, but interpretation of phase 2 result is a little bit too optimistic sometimes. overall rationale itself wrong. So those are rationale issues. Pharmacologies, okay? Interaction with Riluzole. Sometimes interaction with Riluzole, not necessarily good. Riluzole is a good medication, important, but combination Riluzole with the study medication turns out to be not necessarily good idea. And also, dose is too low. It happens. Broad pharmacological issues. We don't know whether medication reached to the target. We don't know medication reached to central nervous system. There's a tremendous barrier called blood-brain barrier. So without knowing whether medication gets to the target in the brain cells, you're doing a study without a clear benefit. And also pharmacokinetic issues, side effect and so forth. Pharmacodynamic is the same thing. I mean, kinetic is blood level and so forth. Pharmacokinetics, again, what the medication change, body, and so forth. And the poor CSF penetration, as I mentioned, bioavailability, very few studies looking at whether medication ever reach to drug target. For example, medication affect or must change motor neurons. We don't know whether medication reached to the motor neurons or not. That's the studies. Also, biomarker relevance. And we don't have any biomarkers, but the biomarkers are such an important things and we have to develop in the future. So design and methodological issues. Yes, expected changes from placebo were too high. Sometimes we don't have enough investigators with limited funds. We wanted to test the medication, so they set 50% changes. If you set the 50% change compared to placebo, essentially you expect a negative study. You have to find small change. And we need small change, multiple medication. If you combine, hopefully you can get additive or a more better benefit. So disease at enrollment was already too progressed. You should realize it takes about 9 to 10 months to make diagnosis after symptom onset. To reach clinical trials easily 15 months and 18 months, so time passes. And motor neurons are slowly degenerating. So when clinical trials started, already we are starting kind of advanced stage. We moved to much earlier stage. How we can do it, major question. 2 primary endpoints called confounding problem. I'm not going into it, that's true. And also study period is too short. You have to try a long time. Disease diversity, heterogeneity. We heard it this morning, a lot of issues with ALS or ELA. ELA is not just one disease, multiple different diseases in it. So we can treat apple and orange together. How can you get positive result? So that's another issue. Imbalance of enrolled patient and requiring different phase 2 studies, yes, okay. The patient population differed from phase 2 studies. Sometimes you want a very optimistic change phase 3 to get more benefit. Turns out to be different from phase 2, phase 3. That turns out to be act against the study itself. Rapid enrollment, off-label medication easily available for anyone. So those are many issues raised by investigators. So another things, at least the symptomatic treatment. Symptomatic treatment means if you have too much drooling, what the medication improve drooling? Or NIV, non-invasive ventilator. If you have a problem with the breathing, how we can develop better device to help breathing. We heard the diaphragmatic pacing today, this morning. Is that kind of symptomatic treatment? And so a medication called Neurologista is a symptomatic treatment for improving pseudobulbar affect. So what turns out to be symptomatic treatment is much easier, requires smaller number of patients and a shorter period of studies. If we improve a patient's symptoms, many symptoms we can improve, clearly improve quality of life as long as patient keep going. So that's the reason symptomatic treatment, I think, is extremely important to do. So just I'm talking about muscle weakness now. Cytokinetics has medication to improve muscle strength and weight loss. Already someone talked about improving weight loss with a high-calorie diet and cytoluria, fatigue, many things we can improve a patient very difficult symptoms. So recommendation future clinical trials. So expand research to find the cause and pathogenesis of ALS. As I mentioned, we tend to pay attention to clinical trials. I would continue maximum effort to do clinical trials without any doubt, because that's what we need, patient waiting for, family waiting for, yes. But without knowing better pathogenesis, we may not get better medications. Pathogenesis, as we heard, so much complicating. Not just one cause. We heard so many genes and so many environmental factors. We have to narrow down. And we have to have biomarkers, objective markers, and other critical issues. Preclinical studies with animal models. SOD turns out to be so important. We used about 15 years or close to 20 years SOD mice, but turns out to be, I'm sorry, but wrong models. So we need to have a better models, and we have to do a better job. And we need to improve clinical trial methodology, confirm, duplicate the studies in independent laboratories. If you find one animal studies, clinician jumped to the conclusion, okay, try that medication in the studies. Probably that's good enough. Independent 2 or 3 laboratory duplicate the same result, then it is okay. But also much more stringent. I have a strong feeling that preclinical animal studies has to be same level of vigorous studies as human studies, randomized, pharmacological, pharmacodynamic studies, and so preclinical statistical analysis. You have to use same level of vigorous studies in preclinical studies. Consider investigating candidate drug alone and Riluzole, because Riluzole is not necessarily good medication to combine. Through transaction from basic science to clinical trials, vice versa. The reason is preclinical basic scientists do animal studies, find the medication. Okay, we find this medication, and clinical trialists like me pick up medication, do clinical studies. There is no true translation. I think basic scientists has to be involved with clinical trials to find medication ever affecting in target, motor neurons or astrocyte or whatever the target. And otherwise, clinical trials and basic scientists essentially dichotomized. There is no continuation. So evaluate the validity of clinical studies by evidence-based. That's very important, and develop new disease model for ALS. We have a SOD model. Perhaps wobbler mouse turns out to be FIG4 models, and C9 models are being developed. So we need a better model without any doubt. But just simply, we cannot rely on animal models. So include other disciplines in clinical trials. You need a pharmacologist, more biostatistician, and so forth. Improve the design methodology, randomized control studies. We developed a very good clinical trial design and so forth, but we are not sure that's good enough. And the next year, we're going to have clinical trials guidelines and international meeting to update clinical trials guidelines. So I'm in charge of setting those meetings. And consider more randomized control trials for pharmacological and non-pharmacological symptomatic treatment, as I mentioned. So plan a meeting, as I mentioned. If clinical trials like me can improve clinical trials, whatever improve, I think we have to improve the clinical trial design. So this is just a scheme. We have to vigorously analyze medication found basic scientist, a medication. We have to know whether that's reproduced and a good medication, good enough to go to clinical scientist. So in the previous studies, little laboratory did a few SOD mice studies. We found some benefit. we picked up those results to clinical trials has to be much more vigorous. So will be changed in this scheme after those guidelines development. So we are doing a lot of clinical trials and some medication procedures, fingerboard for anti-lymphocyte medication, tirasemtiv is a troponin activator, edaravone, methylcobalamin, which are interesting because you should know in Japan, I thought that Japan was somewhat behind in clinical trials. In ALS, turns out to be, I was wrong. They are now ahead of us, and because now they have edaravone being approved in Japan as a treatment of ALS, and also methylcobalamin, which is vitamin B12 derivative, methyl sideline is attached, with now prolonging survival, again going into Japanese regulatory agencies, those medication will be approved. So those medication might or might not comes to outside of the United States, which is remarkable. And the stem cells going on, stem cells are such an exciting, attractive proposition because we don't know anything about. But still, these studies are so important to go to basic level of clinical studies, and I hope they do very right stage to develop new trials, new medication, stem cells treatment. So future clinical trials in Japan, in ALS, excuse me, and a lot of clinical trials will be done without any doubt. And current clinical trial guidelines, as I said, 16 years old, which will be renewed, updated next year. And so I hope we have some representation from Brazil to the conference. So the conference will be March, and we really would like to develop very good clinical guideline for the future. So it was my talk, and just about 35 minutes, so time, and I left some time for question. By the way, so nice to you, Maria, and I saw you 5 years ago, right? And wonderful, I see time to time a patient from Brazil, and I'm honored to see those patients again. It is just incredible to see you. You're doing great and so beautiful. So thank you so much for the time.